Welcome to Around the Couch. I'm Alex, sitting in for Jeff Callis from Kidney Couch. In this episode, we tackle the use of predictive, otherwise referred to as prognostic models, to predict whether a person's cancer will recur, metastasize, and estimate how many years a patient is expected to survive their cancer diagnosis. As with any cancer, one of the questions foremost in a patient's mind is whether the cancer will return in the future, and if so, when is it most likely to return? For kidney cancer, also known as renal cell carcinoma, as with other cancers, patient recurrence, metastasis, and survival data have been tracked for decades. Data from patients who have had kidney cancer is used to predict patient outcomes with similar circumstances. You might be asking yourself, why does a physician need a predictive model to tell them whether a cancer will return or end your life? In the simplest terms, physicians make decisions regarding recommended treatment. To do that well, they rely on many data points: imaging, lab tests, overall health of the patient, environmental factors, etc. Using a predictive model is one more data point they use in their practice. In healthcare, physicians rely on their experience and patient outcomes to guide treatments and recommendations for future patients. As with any occupation, knowledge and confidence builds over time with experience. That is certainly true in healthcare. But physicians don't have to rely on their experience alone. When it comes to predicting outcomes of a patient's cancer diagnosis, there is a vast amount of patient data and outcomes in databases or patient registries all over the world. Many medical and scientific publications discuss the cause, effect, outcomes, and future prognosis of many diseases. Kidney cancer is no different. Cancer statistics often use an overall 5-year survival rate. That doesn't mean cancer can't come back after 5 years. Kidney cancer can return many years after first being found and treated. Cleveland Clinic states that the majority of recurrences occur within the first 5 years. Recurrences after this 5-year period are known as late recurrences and can happen years or even decades later, often due to microscopic cancer cells that spread earlier but took time to grow into detectable tumors. Factors like the original tumor's size, stage, and aggressiveness, such as the presence of tumor necrosis, can influence the risk of late recurrence. Every individual is different. No two individuals are exactly alike. Therefore, using averages for patients with the same cancer type, stage, grade, and other key data points is the best the medical professionals have in beginning to answer the questions many patients ask. Will the cancer return? How long do I have to live? A physician's response when asked these questions draws on their experience, clinical trials, studies, registries, and recommendations from leading medical centers and scholars. If there is one thing you can be certain about in predicting outcomes from kidney cancer, is that there is no certainty. Prognostic algorithms can be used to counsel patients, determine the need for therapy after a nephrectomy, stratify patients for clinical trials, and develop appropriate post-operative surveillance programs that are tailored to a patient's risk for disease progression. Several published articles have shown that prognostic model accuracy for renal cell carcinoma is variable, with older models showing significant declines in accuracy when applied to modern patient populations. All models tend to be most accurate within the first 2 years after surgery, with predictions becoming imprecise for late recurrences after 5 years. Some of the factors that affect accuracy of the available predictive models include: 1. Retrospective data. Many of the available models were developed using retrospective data and may not account for advancements in therapies. Most models show a substantial decrease in predictive ability when validated in prospective, real-world patient samples compared to their initial development. 2. Changing treatments. Most of the data used in the models is 5 years old or older. Advancements in treatments that have been implemented in the last 5 years are not fully factored into the outputs of the models. 3. Time horizon. Predictive models are generally more accurate in the short term, within the first 2 years, and less effective at predicting late disease recurrence after 5 years. 4. Machine learning models. New machine learning models are being developed that incorporate clinical and molecular data to improve accuracy. These models also require extensive prospective validation to confirm their performance in real-world settings. For me personally, knowing more about my cancer reduces anxiety. For others, it increases theirs. After my nephrectomy, I had a conversation with my surgeon regarding the risk of the cancer returning. He told me Mayo Clinic has a calculator that will give me an estimate if I was interested. I wanted as much information as possible to understand what I was dealing with. It was my future as well as my wife and 3 boys I was thinking of. There are several predictive models available from some of the top medical centers in the world. These medical centers have conducted studies based on the patients seen in their hospital, as well as including a broader patient population in some studies. I am a bit biased in thinking the predictive model for kidney cancer, developed by Dr. Brad Leibovich and Dr. John Cheville and others at Mayo Clinic, is one of the best, if not the best, for predicting outcomes for patients with kidney cancer. Others agree with that assessment. Most recently, a study in Canada that was published in the Journal of Urology in 2025 concluded that the Leibovich model was the best for choosing adjuvant therapy to prevent recurrence and cancer-related death for kidney cancer. But I'm not here to put in a plug for Mayo. Do your own research regarding some of the best models out there. They continue to be refined based on new information, new markers, etc. What criteria do the best predictive models use? Let's look in more detail at criteria the Leibovich model uses. There are 14 data points that are loaded into a computerized model that estimates a patient's outcomes based on similar patients in the database. The model is called Predicting Oncologic Outcomes in Renal Cell Carcinoma After Surgery. The criteria used are 1. Renal cell carcinoma histological subtype. 2. Constitutional symptoms, illness that affects a person's general well-being, yes or no. 3. Grade of the cancer, determined by a pathologist after nephrectomy. 4. Coagulative tumor necrosis, yes or no. 5. Sarcomatoid differentiation, yes or no. 6. Tumor size in centimeters. 7. Paranephric or renal sinus fat invasion, yes or no. 8. Level of tumor thrombus. 9. Extension beyond kidney, yes or no. 10. Involvement of lymph nodes, yes or no. 11. Age at surgery. 12. Eastern Cooperative Oncology Group ESOG status. 13. Adrenalectomy, yes or no. 14. Surgical margins, positive or negative. The calculation provides two scores. One is the progression-free survival rate, and the other is a cancer-specific survival rate. Both scores are estimated for 5, 10, and 15-year periods. The progression-free calculation is an estimate of whether kidney cancer will recur, meaning the cancer has progressed since surgery to remove the tumor. It's important to note that this predictive model, as well as all other models that predict prognosis of cancer, are estimates only. The results provided from the calculations give you, the patient, a general idea about similar patients with your stage, grade, and other medical factors like your situation. The score is not specific to you. That begs the question, why share this information with a patient if it is not specific to them? It's a great question. I can speak for myself and tell you that the more information I have based on the surgeon's experience and patient outcomes for patients like me, the better. Other patients may want nothing to do with a prediction that is not specific to them. There is no wrong answer to the question. In my personal experience with kidney cancer and based on the research I have done, it needs to be stressed that calculations from any prognostic model is an average based on studies conducted to date, are usually based on data that is at least 5 years old and does not take into account advances in treatment or changes in general, an individual's overall health, lifestyle, environmental factors, etc. When using a prognostic model, the calculations for your predicted cancer recurrence or overall survival are not specific to you. They are averages based on similar patients that have been included in a database. That being said, many kidney cancer patients like me want a more informed prediction of cancer recurrence and overall life expectancy rather than none. Physicians utilize data from prognostic models that have been validated by research studies in addition to the physician's ongoing experience in treating patients and their outcomes. This helps to inform them regarding the ongoing accuracy of the existing prognostic models in the treatment recommendations for a patient's unique clinical presentation. As artificial intelligence continues to evolve, machine learning models will most certainly be developed to help physicians answer cancer recurrence, metastasis, and survival questions. The models will need validation before physicians have confidence in their use in the clinical setting. As with any model, the outputs are only as good as the accurate inputs used to create the outputs. I'm Alec, sitting in for Jeff Callis from Kidney Couch. Thank you for listening. Join us next time around the couch.